Thank you. I like to look at Grace to see what the kind of the real thoughts on what's going on in the world is. So debating against Jack seems to be debating against popular opinion, which seems like a losing battle. But so I'm going to talk about ALK, EGFR, and I put ROS1 in parentheses because I think at least what I see in practice is that ALK, EGFR, and ROS1 are kind of the relatively standard tests that people order. And I think the difficulty is that these platforms are changing constantly. We don't have a single best platform, and costs are variable across the board. And I'll tell you, even at City of Hope, where we have a panel, I can't even get a firm answer on what the panel costs. And so that's a challenge. But clearly, we have driver mutations in lung cancer, and the majority of patients will have a driver mutation that we would argue would be potentially targetable. And I think the question is, in 2015, are they really targetable? And what impact are we making? And in that case, I think that keeping with EGFR, ALK, and potentially ROS is probably still the most beneficial to our patients. So as far as practice guidelines looking to NCCN, testing for EGFR and ALK are the only groups of mutations or gene alterations that have Category 1 data for them. And we've discussed most of that data here today. And so as far as the recommendations, it's all patients with advanced non-squamous cell, non-small cell lung cancer, potentially in squamous cell if there are never smokers, have small biopsy specimens, or have mixed histology. And again, we have effective treatments that are FDA approved and have phase 3 data for both of these, erlotinib, afatinib, crizotinib. No phase 3 data yet for ceritinib, but that's coming. So here we have, I kind of picked the most, probably the most promising of the ones with the most data. There's some kind of up and coming that are smaller percentage, but probably the genomic alterations that have the most data thus far. And I put EGFR and ALK in red, where we have, again, the most data. We now have 3 drugs for EGFR mutation, all with excellent phase 3 data. ALK, we have crizotinib, ceritinib, and others that are coming along. KRAS, there's a lot of evidence, and the majority of patients have KRAS mutations. We don't yet have a good inhibitor for it. MEK inhibitors, yes, have some activity, possibly the CDK4/6 inhibitors, and Jonathan Goldman has been working on this. But we don't have, and the partners and the complexity of the interactions are great. And so it's not like other driver mutations where it's a 1-to-1 and you can kind of get a home run. So we haven't hit a home run with KRAS. ROS1, I think we've hit the home run with ROS1. We have data now just from the phase 1 trial, but excellent response rates. This is clearly a driver mutation or a driver alteration, and I think potentially significantly changes patients' lives who receive crizotinib for ROS1. HER2, again, there's limited data, and not because of lack of HER2 inhibitors. I think there's limited data because not all mutations and amplifications are the same. And so again, as we're learning, as some data was presented recently with dacomitinib, a 12% response rate, different mutations may have different responses. Trastuzumab may have some responses, but it's not the 1-to-1, and we don't get the 50 to 60% response rate. And so it's not a perfect driver, and we need to learn more before that becomes a standard. RET, we're getting more information about RET. And RET inhibitors are multiple targeted therapies that are approved for other indications that have activity, have some level of activity. Cabozantinib, again, presented at ASCO, about 40%. Cabozantinib seems to be effective in lung cancer with 20 to 40% response rates, no matter what abnormality you have. And so cabozantinib seems to be a relatively active drug in lung cancer if we could find the right trial to bring it into the arena. BRAF, So clearly there's evidence for BRAF now with the dabrafenib trametinib data that was presented at ASCO with 60% response rate. So that's emerging. And then MET, there's some activity, and there are new MET inhibitors out there that are looking specifically at this, but it's a very small, generally a small population that's benefiting. So again, moving to the probably one of the best early compilations of patients with mutation, and this was done with the Lung Cancer Mutational Consortium, and this found significant numbers of potentially actionable mutations, and then they looked at survival and found a significant benefit in patients who had an actionable mutation and received targeted therapy, compared to the black and the green, which are those who had either no driver or had a driver but did not receive targeted therapy. But what is in the kind of the fine print is that most of these patients were EGFR and ALK patients. So we're not getting a great bump in this benefit from the other minor players, not at this time. Then moving toward, oh, this is not the new, bummer. I had some other slides. These are the old slides. I think it's just moving toward and thinking about squamous cell. It's even more complicated, and so it's complex genomics. Driver mutations are rare, or they're complicated by other interactions, and so another very difficult area to deal with. So what I had up here was a report from Foundation One, where there are about 6 or 7 gene alterations, none of which have any bearing on the patient's treatment today. Even though some of them, like NF2 and things like that, potentially say there are approved drugs and other indication and other diseases that are potential, but we don't have data on this. And so that was part of the point, was just to show these targetable, potentially actionable mutations have very little data. And so what we're really working on, in the most part, is ALK and EGFR. The other slides that I had were from a trial that was done in lung cancer. So kind of the first published basket trial that was in a JCO just earlier this year, and they looked at multiple sub-cohorts and tried to get targeted patients, their targeted drug to the mutation that they had. And again, outside of EGFR and ALK, they couldn't accrue to the cohorts. They couldn't get the patients in. And so they found a benefit in those patients who received targeted therapy, and they screened 600 some patients. So they were able to do it, but at the end of the day, it didn't pan out to getting them the right targeted therapy. So just the point of that is that I think we're not quite there at getting the patients the right targeted therapy. On clinical trial, maybe, but not quite there yet. And then the last piece is cost. And again, so if we don't have the benefit, or not proven benefit, but there are exponential costs to doing, and I still think there are, even though we can do lots of genes on lots of panels, there's still more cost than doing the simple EGFR and ALK. We're doing a lot of, we're costing people a lot of money here. And this is just something recent from the Journal of Oncology Practice that looked at, this was in breast cancer patients, but just looking at what insurance are paying for, what patients are paying for. But this often, even though it's only a small amount, it's still in the thousands to hundreds of dollars that patients have to pay for a single test. And we're not talking about doing one test anymore. We're talking about doing tests at multiple time points. And so this is adding to it, but yet not significantly adding impact to the care. And so I think the biggest impact is still EGFR and ALK. And then moving on, so again, when we do a next generation panel, we can now add fusions to that. We can get the mutations, but we're not getting PD-L1, which may or may not be the most important biomarker for checkpoint inhibitors. But there are lots of places we're not looking. And so now the whole world of OMICS crosses multiple pathways. And so how are we going to integrate all this? How are we going to make it blood-based so that we can actually make it easier and then cost-effective? And so I think we're in an area of moving target, And proving impact is going to be an incredibly important thing, especially when costs are high. If costs come down, we can do all of this on everyone, but we're not there today. So again, we'll say start with EGFR and ALK and ROS1. And the pretest probability is one of the most important things. So if I have a patient, and this is Southern California, in my clinic in Southern California, I have a large number of non-smoking Asian female patients. If I have a non-smoking Asian female patient standing in front of me, what's the chance she's going to have EGFR mutation? 60%, 65% probably. Very high. So why wouldn't I just do EGFR on her? And I know some of the Kaiser systems, they do EGFR first, then they reflex to ALK, then they reflex to ROS1, which kind of drives me crazy not to get all the answers at once. But cost effective, I mean, especially in Southern California, where that EGFR is going to be very much the highest one you're going to see, may be cost effective today. Again, moving on, that may not be true. So anyway, so again, the trials for ALK are still the validated FISH assays. We're moving toward kind of more of NGS assays toward that, but those haven't been validated in the trials. How are we going to integrate that? And we need to decrease costs. We need to help payers understand the impact that this is important. And often patients need therapy right away, so still getting the standard PCR. Many sites will do the NGS and a PCR for EGFR because they know they want to get patients on quickly. And then therapy potentially to the brain for somebody with EGFR mutated or now even ALK translocated lung cancer could be started early by just starting the TKI if they get the answers quickly rather than waiting several weeks, which still is usually the case for NGS. So, and again, it's still the only Category 1 indication. Thank you.